Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Avi Bhar. Dr. Bhar is a pulmonary and sleep physician. He is board certified in pulmonary, critical care, and sleep medicine, and he also holds an MBA from the University of Chicago. Dr. Bhar's areas of expertise include sleep apnea, asthma, and COPD, and he has published numerous articles in leading medical journals on these topics. Dr. Bhar recognized the shortcomings of the U.S. healthcare system and the opportunities made possible by advances in mobile technology. So in 2019, he decided to leave his private practice and establish Sleep, a telemedicine practice founded on high value and personalized, convenient, and cost-effective sleep and pulmonary care. I'm often asked by colleagues, Mike, what do I do if I can't find a like-minded medical provider in my area? This is a real challenge because oftentimes I find we will embrace the concepts of the importance of nasal breathing in young children and even understand the role that the dental provider can play in that process. However, as I often say, the etiology of sleep-related breathing disorders is multifactorial. Therefore, the solution needs to be multifaceted and often multidisciplinary. That becomes a challenge when either the medical community doesn't have like-minded dental providers or the dental community doesn't have like-minded medical providers. That is why I'm super excited to discuss Dr. Bhar's creation of Sleep as a potential solution to that problem. Throughout today's episode, we are also going to discuss the numerous challenges and flaws associated with the traditional model of healthcare, particularly as it relates to sleep medicine, why there is a shortage of sleep physicians in the U.S. and how that is impacting sleep-related healthcare, the lack of training that most physicians and even many sleep physicians get in sleep medicine, the issues with using polysomnography as the only indicator of airway disease, and the importance of a thorough patient evaluation and use of clinical symptoms for diagnostic purposes, why women and children are the biggest sufferers of the dental and medical profession's ignorance on sleep medicine, and much more. This is such an exciting episode as we are going to dive deep into this area of sleep medicine with an expert to dispel a lot of the myths and rumors that exist, especially in the dental profession when it comes to this topic. So without further ado, let's get on to today's episode with Dr. Avi Bhar. Enjoy the show, everybody. Welcome to Doc Podcast, Avi.
Thank you for having me, Mike.
Thank you so much for coming on. Interesting how we met. I was giving a lecture up in Atlanta at Andy Letcher's study club, and you were there, and I really appreciate you being in attendance. And then afterwards you came up, and we just got talking about how similar our philosophies are on a lot of this, and really enjoyed hearing you talk about Sleep, which we'll talk about today, the company that you have developed and the virtual platform that you have developed. I think it's really, really amazing that you're doing this, and it's a huge, huge add to our profession, both on the dental side and on the medical side. And as I do have a lot of dentists, physicians, and laypersons that listen to the show, I'm really excited to be able to touch on that as well as dive into many of the issues that a lot of people on a lot of levels, even those directly involved in sleep medicine, may not understand. So before we dive into that, tell the audience a little more, if you would, about your career, your journey. You had experience in private practice and then went into the arena you're in today with sleep. You also have your MBA. So if you could talk a little bit more about all that, I'd love to hear.
Yeah, no, thank you for having me, Mike. It started, I was wrapping up my fellowship. I was PGY 6 at that point. So that's postgraduate after medical school, 6 years of training. I did my internal medicine for 3 years, and 3 years into my into my fellowship, I somehow did not feel that I had finished my journey. And so I went to my mentor and I said, there's an interventional pulmonology fellowship or there's a sleep fellowship. What do you think I should do? And, my mentor, Dr. Mutaya, had said, you can be a better physician to your patients if you understand their sleep issues as well. And so that started. It wasn't difficult. Once I heard that, I was like, yeah, that makes sense. And I went to WashU to do my, I was at UT Memphis and then went to WashU to do my sleep fellowship. And I was grateful because WashU, the sleep fellowship or the sleep department is under the Department of Neurology. And I think that really changed the perspective of how I viewed sleep, because it added to what I already knew as a pulmonologist about the breathing issues and so on that generally patients encounter. I did my sleep fellowship and started practice, moved down to the deep south. It was about an hour and a half south of Atlanta. And at that point, I realized that, even though the future was here or present, but it was unevenly distributed in terms of the level of care patients are actually getting. And the stuff that I was solving for patients struggling with this for years and years and seeing other doctors in the community, I realized I was solving this easily is because I was fellowship trained and this came second nature to me. And, patients were driving long distances. And, I still, that feeling of, I wish I could do more started kind of permeating within me. I was like, there needs to be a better way. I did my MBA because, again, going back to what kind of drove me to do my sleep fellowship, I just felt like my journey of learning hadn't ended yet. And one of my best friends was pursuing his MBA at Wharton. And I was like, that sounds interesting. And he told me about it. And I was like, man, this is great. My idea was I'd do my MBA and I'd become a physician leader within the healthcare system and be able to impose change or make change and do better for my patients. And I realized at that point, when I completed my MBA, that the people running the healthcare system really had no right over my career. It was not patient-centered. And there was no focus on actually what mattered most to patients. So I kind of, after 2019, which happened to be my best financial year, with all the RVUs and so on, I was Palm, critical care, and sleep. I left it behind because it wasn't feeding my soul. It wasn't giving me what I wanted for my career. And I took a sabbatical, thought about what I did, and I realized what I did wasn't rocket science. It was, you need to listen and you need to be able to actually solve patients' problems. And just like psychiatry, sleep medicine is really built for tele. And so I decided that I'll set up a telehealth practice in early 2020, and COVID hit after that. And the rest, as they say, is history. So the practice has been, growing in that sense because, again, patients, initially I thought, okay, it's going to serve a need in the rural communities because that's where they don't get enough sleep doctors, because the US only produces about 150 sleep doctors a year on average since the fellowship started back in 2012, I think, or 2011. And only this year, the class was 200 sleep doctors in the whole country. So if you think about that and the millions of patients out there struggling with sleep, there's a huge disparity. And I could see that firsthand where I was, that patients were not getting care. And it wasn't complicated. You just had to recognize that there was an issue and address it, and not just say a test is negative, I can't help. Because a patient comes to you with a sleep issue and the test is negative, so what? You have to figure out why. You have to give the patient an answer, or the referring office, whether it's a cardiology office or a psychiatry office or even a dental office that screens patients. Why are they sleeping poorly? Why are they bruxing? Why do they have headaches? Why do they have anxiety? Why do they have depression? Why are they on thyroid medications for fatigue? All of these things, and not saying that none of these things exist on their own, but if a patient has a few comorbidities, the question is what's underlying, what's driving that?
Yes.
I think a lot of times in healthcare, we play whack-a-mole, but we have to actually take a step back and look at what may be driving this. And frequently sleep is overlooked because it's seen as a passive process. Something you do once you do all the important stuff in the day, then you get whatever sleep that you can get, and that's this whole sort of machoistic sort of look to it, like, I got 5 hours of sleep last night. I'm still doing well. I'm taking my 5-hour energy drink. I'm taking caffeine. I'm smoking cigarettes, and then I'll have a drink at night to help me sleep, or I'll take a medication to help me sleep. And so sleep has always kind of been looked as a passive process, a side issue. But I think now that the data is slowly coming out that it's driving everything that we're seeing as problems, whether it's heart disease, whether it is mental health issues, whether it's related to your blood pressure control. I think it touches every facet. Our blood, a blood sugar control as well, the metabolic syndrome. A lot of that is triggered by poor sleep. And, we always blame weight, but we also know now that actually sleep apnea triggers weight gain. It's not necessarily you lose weight, sleep apnea will go away. There is an airway issue. And that's why when we were at that talk, when I attended your talk, I was probably the only sleep physician or any physician in the crowd. But I was nodding my head excitedly. I was like, this is what everyone needs to hear. Dentists need to hear this because, no one looks at the back of someone's throat more often than you all do. I mean, it's crazy. We really have to be able to actually work with everyone across the board. And, a lot of times if a dentist screens a patient, we need to be able to then understand what's going on with the patient, why they're there, and then provide the right therapy to them. So that was how kind of my journey ended up with setting up the sleep practice. And we're going nationwide in a few months, and we run everything through the patient's health insurance. And it's been a really it's been the hardest thing I've done in my life, but also the most fulfilling thing as well.
Yeah. Struck by so many things you said there. And that's why I love hearing people's journeys, because people know you as the Dr. Bhar you are today. They see you, they know the role you're in, and they don't realize how grueling that process can be to get there. I mean, obviously most people know from your credentials that you went through a lot in school, the choices you made, having a mentor, Dr. Motaya, you said?
Yes.
Having someone who was there for you. I find so many of us have those people that are just a light to kind of guide us in a little different direction or help us gain a different perspective on something. And then the feeling that you could do and be more. Mm-hmm. Clearly you were driven to do more than just treat disease. Mm-hmm. And that to me is so exciting, because that was a lot of my motivation as well. I mean, I was loving what I was doing in private practice for almost 2 decades, running my own practice. And as you said, very lucrative, doing, and to turn that down to go and dig deeper into a cause that you wholeheartedly believe in and see a need for isn't an easy journey. So I want to acknowledge you for that, because it's not easy to walk away from that. Clearly, not a lot of people do what you did. And when you're in that system, I find, especially with my medical colleagues, although my dental colleagues as well, once you're in the system, it's really hard to get out of it, right? You kind of become a victim of the circumstances. It's that proverbial frog in boiling water, right? People look, you come out of school, whether it's medical or dental school or residency or your postgrad, your postdoc work, and you're enthusiastic, you're energetic, you have all these ideas, and it's almost like the system breaks you over.
Well, it co-opts you, right?
Yes, it's a better word for it. Yeah.
And like even the dirty little secret that you'll find that I was part of as well is, when you send someone to a local sleep doctor, he's likely credentialed in a sleep lab. And even though 98% of patients should get a home sleep test, and we do multi-night testing because that's a much better baseline. Mm-hmm. A one-night hit is a hit or miss. Mm-hmm. And if you miss it, the patient's going to walk away thinking that everything's fine. But a local sleep doctor is going to get paid 3 times more to read or interpret a sleep study in a sleep lab. So when you're in front of them, what do you think they're trying to do? They're trying to find reasons why you need to go into a sleep lab. And that's the way they get their bonuses. And I think a lot of times with now the high deductible plans coming in play, most patients end up being on the hook for a large amount, and then goes back to what sleep has been. It's seen as a passive process. Oh, I'll deal with it. Oh, it's not important. I have other things to deal with. I have my blood pressure to deal with. I have my mental health to deal with. So then sleep, the priority goes down. And, sleep is a single player game. We don't see know how someone else sleeps. If someone's hurt, injured in the foot, we see them struggling. They're having breathing issues. We see them struggling. It's a very visual sort of cue that we get from them. Mm-hmm. If someone's down and depressed, you can tell immediately. But because society has all these sort of aids, whether it's, cigarettes or stimulants, caffeine, or even now, you can get Adderall just because you have adult onset ADD. There's different ways of coping. So then sleep goes further down that list. And if you don't have a good partner or sleep practice that actually can help you, I think a lot of times the wait time to get in takes 6, 12. I was on another podcast recently where they said, in their area, the evaluation by a sleep practice or a sleep lab was 9 months away.
Wow.
I mean, it's crazy. And that goes back to the number of sleep doctors being produced and, the reimbursements going down for sleep labs. So they're cutting down the number of beds. But they have, this local sleep doctors keep feeding that sleep lab because guess what? They need to kind of earn their living as well. Yeah, you're right. There's a lot of co-opting going on. Again, going back to what you mentioned as a mentor, we stand on the shoulders of giants. We get help from people that, and it would be remiss for me to not mention the fact that I was lucky because, yes, I was a physician and I still am, but I was a critical care physician. So I could do a week, a month in the ICU and still earn a reasonable salary. What most people don't realize is my wife is also a physician and she earns a decent salary as well. So that allowed me to take a risk and say, you know what, I'm willing to give that up. I mean, that's why I think, as you say, when you see someone, their credentials, it still hides so much more that's going on. And I really count myself lucky that I was able to have that support. My parents as well. I mean, I don't know why my mom would bring me all these business magazines and all that stuff when I was 12 years old. And I would just see that and understand that. And that's the part of the reason why I did my MBA. It was like, oh, cool. I can make sense of all of this now. And I had that desire and that sort of upbringing as well. So it's been an interesting journey to say the least. But yeah, you're right about the co-opting, that there's a lot going on and we get stuck in it and it's hard to get out of it.
It is, especially when you then increase your, you just said beautifully how you had some other options and other ways to help afford some of the lifestyle expenses that we all have. And so we get out and we've spent all this time in school and we've lived like poor college students and medical dental students and residents for all these years. And we get out and all our friends, especially in my arena, my friends that went into the business sector, I mean, they came out of college and they're making tons of money and you're seeing this and it's that delayed gratification. Okay, I get it. But you get out and you're like, okay, now I kind of want to, you're 30 years old, a lot of us by that point. I want to start experiencing a little more in life than living at sort of the bare bones of
student lifestyle.
Student lifestyle. And I see it all the time in residents and in young docs that I teach and coach. And one of the things I try to encourage them to do is to keep those lifestyle expenses modest in the beginning. Yes, maybe now you can afford a little nicer vacation or a little nicer automobile or a little nicer house, but you please don't go making crazy changes and increases in your expenses because you will be more susceptible to the co-opting by definition, because you can't discontinue taking a particular plan or stop participating in a particular hospital's credentialing process or whatever it is, or signing up for another healthcare plan that will bring you more patients because you need to pay those bills. And so that freedom, and it's something I tie into this show a lot. I do episodes on the financial freedom side of things, is really truly what allows those of us who are able to make these alternative lifestyle decisions because we all need, there has to be a certain amount of income coming in to cover our expenses or we can't live the life that we hope to live. So it's just a reality that I'm glad you highlighted that part of it. The other thing I want to touch on that you mentioned, a lot of things I want to touch on, but one of the major ones is the issues with sleep studies. So I still have a lot of my orthodontic colleagues, when I'll kind of go back and forth with them in some of our online groups, that literally say, and this isn't a child, not even an adult, unless they have a sleep study with an AHI of 1 or greater saying they have OSA, I don't pay attention. They don't have a sleep issue. They don't have an airway issue. And you and I, and you just mentioned some of it, that lack of sensitivity, the high incidence of false negatives. And you mentioned when we've spoken before that the negative sleep study is not truly negative in the absolute sense of the term. And you also mentioned mild sleep apnea is not always mild. So if you could just shed a little bit more light on that as a sleep physician, someone who has been deeply immersed in this for so many years, how do we make sense of all of this?
I think going back to the AHI of 1, and that's a pediatric cutoff for positive sleep apnea or a sleep study that shows obstructive sleep apnea or any kind of sleep apnea. That the home sleep, the in-lab test is fraught with, even though we consider it the gold standard, it really truly isn't, because there are false negatives because of a first night effect. People don't sleep the same way when they're being observed and they're all wired up and, people coming in and out and noise going on outside. There's a lot of this. You never actually sleep. And that's a one hit or miss situation because, again, this, when you wake up certain days, you feel great. And some days you're like, I'm dragging. Why? If I were to tell you, well, some days you feel hungry and some days you don't, you're like, whoa, what's going on? There must be something wrong, right? So, I think, the in-lab test has been kind of revered this whole while, but I think the home sleep test really needs to be given at least a chance because it allows for multiple nights of testing. And we've seen as well that as you do more nights of testing, the false negative rate goes into even the single digits, which is great, which is what you want. And it always ties back to the clinical symptoms. It comes back to the patient, which is old fashioned. But if you cannot explain these patients' sleep symptoms, then you have to keep looking. You have to explain that. Not your test is negative. Because if someone comes to you for pain and you're like, oh, I did an MRI, it's negative, I can't do anything.
Right.
That's not the answer. The patients come to you for help because they're struggling with something. I mean, yes, they are hypochondriacs, but they're not as many as you think. And patients just do want to get better. And you can see from the medication list, they are struggling with something. They're trying to cope with what they're dealing with, and no one's listening to them. So home sleep testing has been great. I mean, even for children and pediatrics. And I've had even when I send a patient to an ENT and they've had a home sleep test, they just kind of brush it off and say, "Oh, I need an in-lab test." And I'm like, why? Like, why? The patient's symptoms matches the test results. Now you send them to an in-lab test and they end up having a false negative because they have mild sleep apnea, which we'll go to in a while. But that you can have the night-to-night variability of sleep, and if one night you're less than 5, you're screwed. No one's going to take you seriously and no one's going to help you. And so then, but again, the idea is that there's a test that's going to override our clinical judgment.
Right.
I mean, I think that's scary that people practice that way, because we really have to go back to the patient, and the human being is struggling. You have to figure it out, or give them an answer, or figure out who else can help them. But to say that, oh, your child doesn't, we've had, that's why we started seeing teenagers as well, is because they were not, we were treating their parents and they were recognizing symptoms in their kids. And we started getting more and more of those referrals, and we had to start seeing teenagers as well. But a lot of them, they don't get tested because they get told, oh, it's put your phone down, or do this, or you are doing this to yourself. I mean, there's so much blame on the victim here. And if they're not sleeping well, it behooves us to kind of figure out why. So, I think a lot of times, the idea that we test someone and they come back negative, is it truly negative? Can you explain the symptoms another way? And then what you mentioned, the mild sleep apnea diagnosis, which has been, I think, a burden on so many patients, because they're told flat out, oh, it's mild, you don't really need this treated. There's been no studies
or
that
insurance won't cover it, right?
Which I think is also, we've not had a problem because we document symptoms, and a mild result with symptoms equals coverage. Otherwise, you have a right to actually do a peer-to-peer to kind of overrule that. We hardly get that because we're documenting symptoms and the test result to prove that. And with mild sleep apnea, a lot of times we assume mild is mild in the effect on us, but there's no studies that have shown that. Your symptoms don't match that. Some people can have severe and can have very few symptoms. Some people have mild and have a lot of symptoms. So it really is an individual thing. And if we do multi-night testing, you'll see there's a lot of variation. Sometimes they'll go into the moderate range. And, the idea that someone has mild and it equates, the only time the severity of your sleep apnea equals something greater is heart disease risk and stroke risk. But how you live your life, your quality of life, the effect on your fatigue, the bruxing that you do, the waking up unrefreshed, the multiple awakenings, the waking up to urinate, all of these things are symptoms of something that needs to be addressed. Headaches, people are getting Botox. We keep treating the symptoms because the MRI was negative. I'll offer them Botox, but you should actually try to find out why this human being has a headache, rather than saying, I'm going to just put a Band-Aid on it and stick you with a needle or give you a chemical to kind of treat that. I think, a lot of times, because there hasn't been enough sleep doctors around, and they're also backed up, they're all co-opted within these large systems where, it's a 6-month wait or a 12-week wait. A lot of patients then fall off the wagon and they don't follow through. And that's why you've seen this graph that they show about, patients who have sleep apnea, and then how many of them actually get seen, how many of them get tested, how many of them get treated. The number falls precipitously is because we have this 4 to 6 month wait time, which is unnecessary. It's putting every patient through this sort of cattle sort of pathway of going, okay, you wait your turn, you're going to be next, we're waiting for your sleep study to be done in a couple of months. Why do you need a sleep study in a sleep lab? Oh, the doctor says so. But why? And so I think a lot of times the mild, the negative needs to be looked at, and you always have to come back to the patient's symptoms. Can you explain? And that, we've talked to a lot of other referring practices, and what they find is that they'll send them to a local sleep doctor and they're told the test is negative. Go back to your primary care, take some Seroquel to help you sleep, take a Trazodone, take a Remeron, take all the sleep aids, take a melatonin. And now, we see melatonin as well getting caught in this whole issue of increasing risk of heart disease and stroke risk. These are the same risk factors for sleep apnea. We're using melatonin in patients who actually shouldn't be on melatonin, and because it's readily available in your CVS and Walgreens aisle, patients are coping. They're not treating the underlying sleep issues. They're treating their symptoms, and we are allowing it, assuming that it's just fine. I don't think melatonin actually causes, again, I may be wrong, but based on my experience seeing patients, I don't think these medications truly do cause heart disease. I think we're masking the symptoms with these medications, and we are allowing the stroke risk, heart disease risk to actually perpetuate. And that's why you see that uptick in patients with melatonin. They're just trying to find ways to cope with their sleep issues.
That's such a cool perspective on that. And I love that you are diving deeper into the etiology. That is my why into doing this as well. I mean, so many of my orthodontic colleagues, and I don't say this as a criticism, it's just the way we're trained. It's how we're co-opted into this process through our schooling. I think I'm going to, if you permit me to do so, I'll be borrowing the co-opted terminology for this rather than brainwashed, because that's it could be a little harsh, but it's a co-opting. It really is. You become a victim of the system. And so many of us get so focused on treating malocclusion, which is our disease, right? I mean, that's our end stage disease essentially. And we don't look at it like that. We're just like, oh, teeth are crooked and our job as an orthodontist is to straighten them. And one of the things I push so hard for, exactly like you're just saying, why? And can we get at this earlier?
Why are we the only animals in the animal kingdom with crooked teeth? Right?
Thank you. Right. And why didn't we have crooked teeth en masse until the Industrial Revolution? And it's only gotten progressively worse since. I mean, there are people I coach and train and work with. It just happened last week that someone said, I feel like every other patient who walks through my door fits the symptoms that they had heard me lecture as well, that you lecture about. And the way these patients look, the airway problems, the dark circles, the venous pooling and allergic shiners and narrow arches and chapped lips and chapped gums, as I call them, and all these symptoms and signs of a sleep-related breathing disorder. And orthodontists are noticing it, those who are looking for it, who are looking at the patients.
So once you see it, you can't unsee it. That's the scary part, because now the crazy part is like I'm out socially, I'm looking in people's mouth. I'm like, oh, she has a sleep issue. He has a sleep issue. And you can't stop yourself because it's everywhere.
Have you heard about the Doc community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off Doc educational materials. Just go to Facebook and search for the Doc community and submit a request to join the group. And now back to the podcast. It is. And I love that you're diving deeper into the etiology and the why, not just treating the symptom. And it's that Peter Attia mentality. It's that need to evolve. I call it, or we need to get to orthodontics 3.0, right? Which is Peter Attia talks about medicine 3.0. We need to have a more proactive approach, and sleep is at the heart of so much of this. And I also love how you explained, yeah, it's because it's this passive thing, right? Like if we hurt our ankle running, it's an active activity that we're like, oh, I've got to back off running, right? I have to throttle it back a little bit or rest. We don't think about sleep in the same context, really at all. And I am a victim. I'm guilty of. I'm embarrassed and ashamed to say it, but it's the truth. And I'm open to admitting it because hopefully it'll help someone else out there who's doing this. I pushed and I was proud of the fact that I was getting 5 hours a night. When you said that, I was like, that was me. And my team would joke like, oh my gosh, you must be a vampire. Like you barely sleep, yet you can perform like this during the day. And I look at it now and it's embarrassing, but I was proud of that. And that's that society of like, look at me, I can barely sleep and still perform at this level. I think it took a toll in many ways, but at the time you just kind of feel like sleep's not that important. As long as I'm getting some rest, then I'm doing fine. And so on that note, how do you so if you could talk a little bit more about that diagnostic process, what that looks like, these symptoms the patient comes in with, because as I often talk about, this sleep disordered breathing or sleep related breathing disorders, they are a spectrum with obstructive sleep apnea at the end stage disease, the most severe, ranging from primary snoring to upper air resistance syndrome, obstructive hypoventilation. And you can have major airway problems as a child or an adult and not have obstructive sleep apnea. So how do you start to decipher How do you tease that out? How do you parse that to determine where this patient fits along that spectrum if you're not just taking that sleep study as the absolute? What are some of those clinical signs and symptoms that you're looking for in your patients when you say we have to look at that patient in greater detail?
Good question. And so, this wasn't taught to me. It's just as you see this, it becomes like you mentioned all these, it's a pattern recognition, right?
Yes.
You come and you see patient walking with the same medical baggage.
Yep.
And, I'll sometimes joke with them because, I don't want to sound cocky, but I'll tell them, I said, you have a sleep issue. There's no doubt. And we'll fix it. And they're like, why? I was like, well, either you're genetically deficient or there's something that's fanning the flames of all these issues you have. And I don't believe that you're genetically deficient. It is likely something that we're missing the mark on. And a lot of times it's the menopausal woman that is on an ADD medication because she can't focus anymore. And then she's on an anti-depression medication. And then she has a sleep aid. There has to be a reason why this human being is failing at this. Sleep is a process where it's like a promise. It's like you eat, you feel full. If you don't feel full, there's a problem. If you go and evacuate your bowels and you don't feel completely evacuated, it's a problem. If you're sleeping and you don't wake up refreshed, there is a problem with your sleep and we need to figure it out. It's not another supplement. It's not this, it's not that. Is that we need to figure out what's going on. And usually, kind of explaining your symptoms. We rarely see in our practice. And again, patients don't come to a sleep practice when it's the first night that they had poor sleep. They've been struggling with this for years and years and years. And sleep changes occur very gradually over many years so that our understanding of actual sleep or how we should feel like changes as well. The reality of what we think is good sleep changes because we start blaming life and career and family and everything else. And I'll get through this phase and I'll feel better.
Yep.
But we won't. My personal journey was, I was probably was 41, 42, started snoozing in more, which I never used. I used to love my mornings, having a morning coffee, waking up before the crack of dawn, catching up on journals because I was, a Palm critical care sleep physician, long days. And that was the only time I had my respite. And I started snoozing in more and I was waking up with a little bit more morning anxiety. I used to love my mornings and kind of figuring, okay, what am I going to do with the day as opposed to, I have a checklist of things that I need to get done. And the other bizarre one was night sweats. Just like a menopausal woman, I used to wake up and my shirt was drenched. And I would have to frequently just pull off my shirt at night. And again, this disease is so common that it manifests. They talk about common presentations of common diseases and uncommon presentations of common diseases. This disease is so common that even the uncommon ones are actually so common and prevalent. We're just not tying we're not connecting the dots to it. And I think when someone has headaches or when they're coming to you with poor sleep and they have a headache, they have a sleep issue. If they're coming to you and they're brux and they have a sleep issue, they have a sleep issue. If they come to you and they have high blood pressure and they're not sleeping well, it's a sleep issue. The figuring out is trying to ensure that we understand what the underlying cause that's fanning the flames, whether it is a chronic inflammatory disorder or whether it is even an autoimmune process. There's something that's triggering this. Because our body, I think we all can admit here, not sound like crunchy quacks. We don't want to sound like, if you inhale some lavender, you'll be fine. But, our bodies are pretty amazing machineries. The way it works and the signaling pathways and how it is down to the minutia that we don't even understand right now. And then all of a sudden we're accusing it of not working well, and then, you need to have this chemical supplemented. You need to have that chemical supplemented. And the question is why? What is it? We blame, yes, we may be ingesting stuff that may be contributing to it. But I think a lot of times it's something that's going on. And like you brought up malocclusion and the crooked teeth, our skulls, from what I understand, is at its smallest state that it's been in our evolution. And our diets are changing. So we have smaller jaws, and when you hit middle class, even I was back in Asia, and you hit middle class, it was a rite of passage to get braces for crooked teeth. So what they do is pull out more teeth. And then it narrows down your airway even further. And I know you preach this, so that's why I was sitting at the back of the room listening to you going, this is it. Everyone needs to hear this. Because even for me in my journey, I was trying to piece together because I kept thinking, am I seeing this because I have a hammer in my hand and everything starts looking like a nail?
Right.
And the validation has been not only recognizing it and then testing them and getting a positive test, but putting them on therapy and actually changing lives. That's been the beauty of this process. So that validation is there. I don't feel as crazy anymore. And as we hear more of our dental colleagues talking about this, you're like, oh, okay, that makes so much more sense. I get it now. We are facing an issue. And, you know, a lot of young kids, like you mentioned earlier on, no one's recognizing that. A lot of women, no one's recognizing that, because a lot of sleep tests, the data has been validated on a largely male population, an overweight male population. And when you test data on that, or when you validate your sleep testing data on that, it's skewed to the more of the, what I call the peacocks in our society, the males, the more dramatic presentation. But women and children don't manifest these symptoms as dramatically. Like even for issues like sleep apnea, women tend to use the word insomnia more. They tend to use fatigue more. Now, in the medical field, when you hear fatigue, you have a checklist. Oh, I'm going to check this patient's B12. I'm going to check the patient's thyroid. I'm going to check the patient's complete blood count. I go through this algorithm, you know, kind of how the system's taught you. You hear a word, this is what you do. You hear this word, this is what you do. And so we go down and then we hear insomnia, and we don't do anything more than say, oh, they need a drug to sedate them. But insomnia for the patient is a symptom. They are coming to you with a symptom of poor sleep. Don't just chemically, they don't reflexively just chemically induce sleep in them, is to find out, why is this human failing at a basic function of our body? Just like if you can't evacuate your bowels fully, you'd send them to a GI doctor immediately to get checked out. You don't say, oh, you can't, let me give you more medications. But just, it has to be, you know, is it a blockage? Why is the body not functioning the way it should? So I think the why behind it is critical.
Yeah, and that's, to me, there's so many parallels in the journey you're on, the journey I'm on. Number one, that it's not readily accepted openly by the establishment. And so there is this element of feeling like you are a little bit out on a limb. That's getting better for sure, thank God, as more people are realizing it. Because as you also said, once you see it, you can't unsee it. And I find, and I don't know if this is happening with you as well, that so often the people who, even some who were skeptical, when they see it in their own children, even more than in themselves, that is when I notice people start to change. People who weren't big on this whole, like, well, there's no real tie between dentistry, orthodontics, straight crooked teeth, and airway. And then all of a sudden they have a child that is struggling to breathe. And they start to think a little bit differently about this topic. And then I've had many who I know, no one was really willing to help their child at all. So they're like, I might as well just try something. They took a course, they just started trying to help the child grow a little better, maybe got a CBCT image, started to look and be a little, get them to an allergist, get them to an ENT, whatever it was. They just started to try to do more. And then all of a sudden they saw their child change. I've had many of those people on this show who talk about that being the impetus behind why they ended up going on a journey to get into sleep or airway related dentistry or orthodontics. So that is really profound. When you see that, you can't unsee it. And I've been
in this field, sorry, I don't mean to cut you off, but this is something that hit me after the fact. Like, I was already a sleep physician, well established in practice. I got diagnosed, and then I realized my son he was 2 years old, and I heard him snore, and I was like, what? What's going on here? Yeah. Because I knew at that point I had a diagnosis. He was kind of hyperactive, and telling us he was waking up tired. Now, if you are not in the field, you blame your child. You didn't get enough sleep last night. You should have gone to bed earlier when I told you to. You know, I told you not to drink that sweet drink. It kept you up all night. You know, we kind of blame the victim so much so, and the fact that I was in this field made me kind of have a different perspective of it. And I realized that I need to help him, and it's so hard to get help because, you know, again, getting a sleep test on him, and thankfully we worked with a very good ENT, and just having his tonsils removed was a relief, because I could tell that he would not complain of waking up tired. He blossomed as a child, and it was nice to see. But I know that this thing is going to come back again as you age. It's not going to go away. Just the tonsils removal is not something that closes the chapter. It closes the chapter, but not closes the book. You know, there's going to be a next chapter when they hit a certain milestone. And again, So we're looking at trying to figure out what is the next point for him. And again, it's a struggle. It's not easy, but that's why I'm glad I'm in the field, because man, it gives me access to resources. And that's why we set up the practice, is that even though we have sleep doctors all around, you do need to work with someone that really understands what's going on and is not going to report back to you, the sleep test is negative. Good luck.
Yeah. And with that sleep testing in children, if we could for a second on that, I had heard, and I literally not the expert in this clearly, there's a difference between the validity and accuracy of those sleep tests in children, of the at-home ones, in children versus adults. Could you talk to that a little bit, and how is that true? And if so, how you account for that in trying to detect and diagnose these patients' issues?
No, and I think the point that I'm trying to make is not that in-lab tests have no role. We definitely need in-lab testing, but I think the idea that everyone needs the first step as an in-lab test is where I think we cause people not to follow through, because of the higher cost, the inconvenience of taking a child, uprooting them, and then getting a negative test, and then the providers or the doctors kind of believing the test, which then kind of puts the onus back on the victim and saying, okay, now you figure it out. The test is negative. The home sleep test only got FDA approval because of the fact that it could pick up, close to a 90% correlation with an in-lab test. And so if you have that, but the beauty is that you can do multiple nights of testing, which then allows us to avoid this sort of hit and miss type situation. And again, the home sleep tests nowadays are very much based on wearables. So they're less intrusive. They allow even a child to wear it and not feel constricted or awkward using it. So you're more likely to get a better test. And again, the test itself doesn't stand on its own. You have to match it with clinical symptoms. If they have a test that's positive based on a home sleep test and they have symptoms, what else do you need to move forward with therapy, because you have a struggling child? I think, to say that I need more data is great. I mean, if you're in your ivory tower and you need more data, go get your data. But don't put the patient through that, because you are standing there going, I'm not convinced. I need more data. Why? Don't you have enough to act on already? And then trial by therapy. Now, I'm not asking for everyone to go through surgery, because that is a big trial to take. Because, for us, all we have to do is open up the airway for adults, even our child. I've put so many teenagers on CPAP devices. And just like adults, there's some that do well with it, some not so well with it. But the ones that do well with it, you change the trajectory. I mean, can you imagine, just for a teenager or a child, you change the trajectory in life by just that much? Change their whole life journey. And if you can bring about that change, what are you waiting on? More data. Like, we'll send patients to an ENT, and sometimes the ENT are like, no, I'm not going to do it. I'm going to get an in-lab test. And like, okay, the sleep doctor says that it matches, but go ahead. You do whatever you feel that you need to. And I think at that point, it's more of the sort of gatekeeper approach to healthcare. Like, you have to come meet my criteria before I will do anything or bestow my skill set on you.
Yes, I completely agree with that. A couple things there that I want to touch on with the physicians, because I hear that all the time. Actually mentioned that in the lead in the show, that one of the things I get asked, I think most often from people is, Mike, I say that, let's say it's a dentist or an orthodontist, a dental provider that understands and believes in the impact we can have on airway and nasal breathing, the importance of nasal breathing, which I will come back to as well. And then they send them to their medical colleague, say it's the ENT. And the ENT says, nope, they'll outgrow it. Or, let's say the adenoids and or tonsils are obstructive. And they look at them and say, they'll outgrow it. Or, I don't want to do surgery here. Many times, and I've said this before on the show, many ENTs, I know, and nasal endoscopy is the gold standard of evaluating the lymphoid tissue, the adenoid tissue. How many ENTs out there are putting a scope up a 4, 5, 6-year-old child's nose to look at those adenoids? Most of them are not. They're using rhinoscopy. They're looking up the nose. And they're not looking at what you have said so nicely is these symptoms. They're not looking at the whole child, the behavior, the ADHD-like symptoms. So I know I went in a kind of it's a broad brush there I'm painting a lot of these patients with, but I guess just to distill it down, if you could comment on why there are so many physicians who don't understand or even look at the sleep side of things, and will patients really outgrow these airway issues with time?
So, remind me about the second question, but I'll address the first one. It comes down to the data that we've collected now. I mean, I think sleep has kind of slowly gained in prominence and research and so on. So the data on sleep has really come out in the last 10, 12, 15 years, really. A lot of physicians, when we get trained based on medical school information. And even when we do our board recertification, the data that is coming or what we're tested on is outdated.
Same with ortho.
Many years
Same with orthodontics. Yeah.
So, it doesn't filter down to the actual, and again, I think you know this as well as I do, that when you're trained, you're so comfortable in the training and what you were taught and how those algorithms work in your head. That they talk about, there's this, I think there's this Navy SEAL, there's this saying that is out on the internet where you don't rise to the occasion, you fall back on your training, right? And so a lot of us, we fall back to our training and we're most comfortable in our training and understanding, and then it goes, okay, this, that. And so if we don't learn sleep, it doesn't get incorporated into the algorithm. And again, because it's also newer data, most people don't really connect the dots. And I think this problem is compounded to what I brought up earlier with sleep doctors. Up to about 2011, you were grandfathered into sleep medicine, meaning that, there were certain fields that you could take extra credits and you could then get board certified and take a test and get board certified in sleep medicine.
Interesting.
So, and then since then, they stopped that. Now they have got fellowship classes. And again, most patients, most providers are going through 3 years of residencies or whatever they've gone through. To take another year out where they are in debt and having a family that's growing, to do a 1-year fellowship that doesn't pay much more doesn't seem like it. I mean, if it's different when you are like, from internal medicine, you are going to cardiology, that could really skyrocket your earnings, and it makes sense to give up the next 3 years to have a higher potential for earning. So sleep fellowships are not very well taken now, except for this year where we had a class of 200, which I'm glad. But if you see that, and you have doctors in practice that don't really understand this as well, don't connect the dots, and then the support system of sleep physicians aren't enough around that are truly skilled at it, looking for it, trying to figure it out. So you actually have the blind leading the blind a lot of times, and so people continue to behave the way they do. I was taking care of a patient recently, and his brother-in-law is an ENT. And said, no, I think it's a psychological insomnia that you have. And I heard the symptoms. I was like, no, you have sleep apnea. I mean, there's nothing else no, it's not. You need to get tested. I'll do the test. And so I'm waiting on him he has a positive test result. I'm waiting on him to get on therapy, and I'm going to see him back and see how he feels. Another patient had enlarged tonsils. This is a 55-year-old guy that had enlarged tonsils. And he couldn't figure it out. Like, it was sore. He would wake up and feel soreness. Now there's nothing to take out. It was just like a lot of enlarged tissue. He had seen ENT, got second opinions, and he told me the symptoms. And I'm like, you have a sleep disordered breathing, get tested. He's got an AHI of 27. And again, no one put 2 and 2 together, because he was waking up with a parched throat, like super dry. Even a dentist, you'll ask, like, why are you opening your mouth at night, right?
Yeah.
Is an issue. But again, they don't make the connection. So I think that's where a lot of times patients are failed, because the system is not supportive of not listening to them. And, if you go back 40, 50 years, there's so many things that we know now that looks, it's clear as day. And back then it was like, it's some mystery illness. Like, women were just anxious people.
Yeah.
Or
crazy. A lot of that. I saw a lot of those middle-aged women, and they had a list of medications, many psychological diagnoses, and oftentimes going through divorce, familial issues. And I had no idea back then that, Avi, these women, as I'm doing some simple restorative treatment or some aesthetic bonding, they're falling asleep in my chair. And it was a weekend I was doing it. So here it's a Saturday at, 2:00. And they're falling asleep on me. And it never hit me at the time that these women had sleep issues. Because as you said, part of my system, part of my algorithm, and now I'm a resident at UConn in the orthodontic program, one of the best ortho programs in the world. And here I am learning nothing about sleep. So I'm not even making the connection between the fact that this patient in front of me, who has this laundry list of meds and these psychological diagnoses, and is falling asleep at 2 p.m. in my chair while I'm doing some bonding on her, it's a cascade of events of sleep. And it never hit me until 10, 15 years later when I started going on this journey, understanding sleep and airway more. And I can't get these people out of my head that I'm like, wait a minute. And sadly, many of them did have 4 premolars extracted. And I say all the time, it's not like removing the 4 premolars caused her airway problem. She likely had it beforehand, which is why
it just accelerated the process.
Exactly. And certainly didn't help it. And it allowed it to persist. And so then I'm looking at my cases and I'm taking some of these patients, adult patients, and they're coming into me as an orthodontist early in my career, just like that, with the deepening of the bite, the broken down teeth, the wear from the bruxing, and all this breakdown. And I'm just like, well, I can make your teeth straight again. Never thinking that these patients were airway patients. Never. And that is, again, something I regret. That being said, it helped me, I do believe, even subconsciously, get to where I started to see this and analyze this. But if we're not looking at our patients critically, if I just stayed focused on the teeth, or in your case, if you just stayed focused on, say, the insomnia, right, or the enlarged lymphoid tissue that was there, and didn't look deeper, then I can see how easy it is, especially because it's not part of our educational algorithms, to just be like, treat the symptom. And it's a lot more work when you start diving into sleep.
Because you have to convince the patient that this is because they've been told otherwise all this while. You're not their first stop.
Right. Their algorithms, are telling them that. Yep, exactly.
I had another patient that was, I think she was prominent New Yorker, on the board of several nonprofits. And I had explained why I thought she had sleep apnea, and I connected all the dots, and you should have seen this woman's face. She's like, I've been to the 12, I don't know, she mentioned 12 most prominent, they couldn't figure it out. I'm like, but this is what I do every day. This is what I look for. This is my job. This is a skill that I have. I may not be as credentialed as some of these guys or gals, but I'm trying to connect the dots because I have to figure out why you have all these problems. I'm not in my siloed here going, oh, like you said, it's a teeth problem or it's a brux problem. It's like, why are you bruxing? Fine, I can put a plate between your mouth and stop the grinding or the pain that you're suffering from. But why are you bruxing? Is there a reason? Are you on medications that might trigger? Do you have we talk about sleep disordered breathing. And I'll say this, it's not all sleep disordered breathing, but it begs the question why. We need to start asking this question more often. Why, rather than, I need to see this patient in 10 minutes and I need to get to the next patient. So I'm just going to listen to your checklist. Oh yeah, okay, all right. I'll see you in 6 months.
And write this prescription and this prescription because it's quick.
Yeah.
And it's easy. And I guess that ties into they'll outgrow it part of the conversation. I mean,
thank you for bringing that up.
I'll leave it to you. I'll let you dive into that if you would.
I think that's bullcrap. What you have as a child will grow with you. I mean, again, we see this happening all the time. I think in a child's airway, there's just very little room for error. So even a small removal of those lymphoid tissue or the tonsil tissue does allow for an more open airway. It does relieve kind of something what I did for my son. But I know it's going to come back because genetically he has it. And we see this in families all the time. You have a predisposing factor, then you'll hit some precipitating factor, whether it's aging, whether it's weight gain, whether it's change in your health, whether it's menopause, anything that then tips you over. And that's when the symptoms become more prominent. But because it occurs with weight gain, people blame the weight. And they don't realize that in actual fact that they have a risk factor and they can't get the weight off because they're not waking up refreshed. Their body chemistry is different now, and it's signaling them to eat more, exercise or move less. So they gain that they have that disbalance or imbalance of calorie intake and calorie burn. It just has to be that small amount, right? And then you compound that over days, weeks, months, and years, and you gain weight. But we blame all these events. We don't realize that these patients have a risk factor. And the number of times I've seen 30-year-olds and 40-year-olds that have been diagnosed and they had sleep issues as a teenager in their 20s, and no one's actually. And if they were going to outgrow it, why haven't they? Right?
Right.
Why were they still having sleep issues? And they've coped in different ways and medications that you've given them to help them feel less anxious, feel less depressed. But why are they still having sleep issues? So I think, I don't think we outgrow sleep issues, or sleep disordered breathing. I mean, again, if you have clear risk factors like a true anatomical deficit, if you have true weight-related sleep apnea, there are patients who have true weight-related sleep apnea that once they lose their weight, they don't gain it back, but many people do that. We see bariatric patients and even patients on weight loss drugs, tirzepatide and so on now that's been approved for sleep apnea. You lose that weight, you do feel better. So we know that the weight has been contributing to your poor sleep, bias, sleep disordered breathing. But, it will come back to you at some point. Just like how we've seen in all these ENT surgeries where they used to do the UPPP on everyone and snore. It says, I've cured your snoring issues. And then 6 months later, the patient's snoring again and they're not sleeping well again. And now we see the data. That's why we don't do it now, because retrospectively, we realize that it was very much a Band-Aid and short-term. So, going back to your point, I don't think we cure it. I think it has to be looked at in a longitudinal perspective. And that's where I think you can track patients with mental health, and when they start peaking and start having issues, it will get you at some point. We need all physicians and all providers, even dentists as well, to be aware of that so that they're screening patients routinely, because even if they don't have it now, they may have it later, or they resolve because you did something for them, it may come back later. But yeah, no, I don't believe, if my answer was clear enough, I don't believe that we outgrow it.
No, thank you. And the mouth breathing, to me, and I want to hear your thoughts, is a lot of times the canary in the coal mine. It is the beginning of the sign that, and I'm not talking mouth breathing if the child's out, goes and runs the mile in gym class in elementary school, right? I'm talking about throughout the night, throughout the day, open mouth posture, not able to inspire through the nose with ease at rest, especially when sleeping. Many of my orthodontic colleagues, there was actually an article in a journal in the AJODO recently that talked about the fact that mouth breathing is no big deal. It's much ado about nothing. We really shouldn't be worried about this. It doesn't mean anything. We're built to be able to mouth breathe. Talk to that a little bit, because it's hard to argue that we shouldn't be nasal breathers from an evolutionary standpoint, from a health standpoint, whether it's the moisturization, humidification, purification of the air, the incorporation of nitric oxide into the air to make the vasodilation in the lungs more profound, even the effect on the vagus nerve and on the regulation of your parasympathetic versus sympathetic nervous system. There are so many things that appropriate nasal respiration does for our health. I guess I'm confused as to why people will be willing to chalk up mouth breathing as no big deal.
I think, again, it's what the mind does not know, the eye does not see, right? I mean, I think a lot of times when you don't realize the connection, if you think about it, like you said, we're built to be nasal breathers. Period. That's not even up for debate. The reason why we breathe through our mouth is because there's something that's not allowing you to breathe better through your nasal passages, either some sort of obstruction here or here. And I'm a mouth breather and I hate it, honestly. And that started off because I had a tongue tie when I was young, just wasn't recognized. And again, my development changed and so on because of that. I think a lot of times the mouth breathing is an adaptation. I mean, even let's look at it this way. You may not be a mouth breather during the day, but we have patients we know for sure mouth breathe at night, even though they will swear, and I believe them, that they don't mouth breathe during the day, but they mouth breathe at night. Why? Because the body has to find a way to breathe. And if it's not breathing well through what should be the best way to breathe, there's a coping mechanism. It's a response to what is an inadequate system or something that's obstructing you. So, that's why going back to our ENT colleagues, I think, we have to recognize that you do need, my dad-in-law is ENT, so, and I have a lot of respect for him and he's great. I think a lot of times recognizing that opening up the airway is great here, but we need to look at the whole airway as a unified airway, because while we open this part up, there's still a long airway to go. And we need to figure out whether that's adequate to solve the problem. And if we haven't solved it, we shouldn't just diminish its importance because we haven't solved it. Because I think that's what we've done is just cope. We cope with it in our intellectually to say, oh, it's nothing. It's like, going back into the 50s and 60s and you find all these stories that you heard about how patients were treated. And then you realize, oh, what they did, they thought that's going to be us in about 40, 50 years. People are going to look back and like, what a barbaric period. You mean they didn't listen to their patients? They just blamed it on them. And so they thought mouth breathing was normal. I think we'll see that more often coming up soon.
I completely agree. I couldn't agree more with that. And I find that when we see patients with a lot of these symptoms, we don't recognize it because a lot of times, and you alluded to it in what you said, if it's 10 minutes here and 10 minutes in some cases is even generous that you're getting in the room with your physician. One of the problems, one of the issues that's happened in the medical community through the healthcare infrastructure, in the dental community, more through just, consultants that push us to be producing more and people wanting more profitable practices. We spend less and less time diagnosing, at least in the orthodontic arena especially, and more time treating. And so we're told by a lot of our consultants, get out of that consultation room as quickly as you can. Spend less than 5 minutes in there, 1 or 2 minutes ideally. Let your treatment coordinator take over, because you're just going to say something stupid. They literally tell us that. I've had consultants say that. And then, or you're going to open up Pandora's box, and the parents are going to start asking more questions, and you're never going to get out of there and get back to the clinic where you make your money. And what that's done is it's put this pressure on us to be ultra competitive with how quickly we can get out of the consultation room. And if mouth breathing really is a thing, and ADHD related to sleep-related breathing disorders or sleep-disordered breathing is a thing, and if aberrant craniofacial growth because of the way you're breathing is a thing, well, now all of a sudden it's a little harder to get out of that room in 1 to 2 minutes.
Yes.
And
you can choose to be the practitioner that is cranking out just, bread and butter cases, and you'll do very well for yourself. You're co-opted by the system. You'll earn you'll have great vacations. You'll have great cars. But again, once you recognize these things and you realize you cannot get out of there, and that's why, part of what I do in my practice, and all our practitioners also are of the same wavelength, is, it's to connect the dots for the patients, because, the system in sleep medicine has been so fragmented. So what compounds the fact that there's not enough specialists around is that the sleep physicians stay in their lane, they do the evaluation. Then the insurance companies now have bestowed, recognition to sleep testing companies to be their own entity. So they're separate, and they just want to get tested in and out. They don't care what the results mean. They don't care whether they're doing multiple nights of testing. And then the third part is that there's a treatment arm, which is like the DME companies that provide the CPAPs, right? So, when you have this broken system, everyone's wanting their slice of the pie. No one actually gives a shit about the patient in the middle to try to figure that out or help them figure that out. So, I think a lot of times we do a grave injustice. So you just write a prescription, get a sleep test done. Now, I'll get you a sleep lab, fine. Whether you get it done or not, I'm going to see another 20 patients in my waiting room, because, guess what? I'm the only sleep doctor in a 25 mile radius. And then the sleep testing company, oh, this is what it costs you. No payment plan, you pay us all of it or you don't get tested. Patient goes, And so, even like the DME company, which is therapy, think about this. If I was a psychiatrist and I told a patient, oh, you need an antidepressant, and go to the pharmacy and they'll figure out the doses and the type. Like, we have no control over that. So that's why part of what we do is we work with dental offices directly. We work with we manage our own CPAPs, because as a practitioner, as a true practitioner in the field, I need to be able to control the patient experience. I need to make sure it's my default settings on the CPAP, my default mask, that we actually talk to patients about their treatment options. So if they want a dental device, that we actually talk to them about what may look like, what the guidelines say, mild to moderate, making sure that they understand that when they see the dentist, we actually then have a follow-up visit scheduled in 4 months to make sure that we're doing the efficacy testing as well. Because patients are just assuming that, oh, I feel better. Oh man, that's great. I want you to feel better, but I also want you to feel the best you can. And if I have the opportunity to kind of bring that to your life, then I've done my job. And honestly, going back to what the consultant was saying, if I bring you an amazing, if I give you an amazing experience and great sleep, you're going to talk about our practice. That's how you scale in healthcare.
Yes.
Not trying to dump upsell the one patient as much as possible and get them through surgery and get out of there so you can see the next guy and upsell him. The idea is that if you do a good enough job, you will scale, because more people will come to you, and you have practitioners that you vet and you train alongside you to make sure that they're on the same wavelength, that a test that's negative truly is a negative. I think that's what allows you to actually grow your business. And I think that's where healthcare really has to be looked at in a different light, because even with an MBA, I can tell you this, they don't teach you that. It's all about bottom line. But that's why I love doing what I do, is because I can try to balance out and align our incentives. Like the home sleep test. Yes, we could earn more if we send it in lab, but how many patients will actually go through? Are we serving a need?
Right.
if only 50 or 30% of patients get a sleep study because we are forcing them to go to a credentialed sleep lab, are we really better than the status quo?
Right.
And so for us in the virtual world, for us to survive, we have to compete. We have to be better than the status quo. And so trying to ensure that, we're doing things that meets the patients where they want to be met.
Yep.
Make sure it's on their terms, making sure that we talk to them about therapy, make sure that we connect the dots between their comorbidities and their potential sleep issue is what then gets them excited. And that cannot be 5 minutes, because a patient will walk away or switch off the phone with the virtual visit and go, I'll think about it. Mm-hmm. And you've lost that opportunity to kind of bring about change to that human being's life. And like you said, all those women that you were seeing and you'd realize that now that they had sleep issues, I'm sure in a way, it kind of, you wish you could go back to that time and tell them.
Oh, completely. Completely.
Right?
Yeah.
It really sticks with you.
Yeah.
And the same thing as well. I mean, for me and that's why I not that I want to live a life without regrets. I want to be able to do the best I can and bring about as much great sleep, because now I have it. And I'll tell you this, because if I wasn't in this field, I wouldn't have tested myself. And that scares the hell out of me, because I thought I was smart. And I missed my own diagnosis until my wife called me a hypocrite for not recognizing the fact that I would have told the exact same thing to my patient to get tested. And here I was blaming life and thinking that this is going to get better and so on. So, that's kind of come one full circle. So I'm a lot more passionate about this, because I realized that I missed out on it. And I could have missed out on it for another 10 years. And I could have been one of the victims or one of the patients I see that have been told, oh, everything's fine, don't worry about it. Just cope with it.
Yeah. And I think as I often say, the multifactorial nature of the illness it's intimidating to a lot of us. It doesn't fall just neatly within a box. And we like to say, well, and you alluded to this, you can get your tonsils or adenoids out, but that may not give you long-term resolution. And I saw that in practice all the time. Before I even knew, the Bhattacharya study, the classic study that I think it was 2010, showing that only 27% of patients from 40 to 720 days out post adenotonsillectomy had complete resolution of children of their OSA. And I didn't know that came out. We weren't talking about that in our orthodontic circles, yet I was seeing all these patients that not long after that, probably 2013. Boy, I got my ICAT, my 3D CBCT in 2014. So from 2014, 2015, I'm seeing these patients who come in. I notice, because if they've had an adenoidectomy, the adenoids look unique on a lot of times. You'll see just like a little at the superior and lateral margins. You'll see a little bit of lymphoid tissue still. Like kind of a classic look. And so I got to know that look. So I'd look and I'd say to the parents, because sometimes they didn't even report on the history. They forgot to say, and I wasn't doing a thorough enough history. I'm embarrassed to say, but I fixed that. But we're not taught that, right? So I didn't even know. And I'd be like, once I started to see it, say, did she have the adenoids out, or he have the adenoids out? Yeah. Start talking to them more about it. And they'd be like, doc, they got better for a little bit, but like, I feel like they're snoring again. And I feel, because it's also, as I say, the solution has to be multifaceted and often multidisciplinary. And I credit Liz Walker with that last part. I told her, she was on my show recently. I'm like, Liz, I'm stealing the last part to add to the multifactorial and multifaceted. But ultimately, that gets hard. It gets sticky. It gets uncomfortable. Now we can't remain silent. Now we have to spend more time in the diagnostics, right? Because there's this multifactorial illness that we just can't label like, oh, crooked teeth, or in your world, oh, insomnia, right? Or restless leg. We can't just label it. Now the solution is often multifaceted in that, like, and that's where people love to quote the literature in orthodontia. Well, expansion doesn't cure obstructive sleep apnea. I never said it did. Like, wouldn't that be wonderful if it did? But it doesn't. It now.
I love that. Yeah. But it's more to it, just like the UPPP and turbinectomies, and I was going to cure a lot of things. It doesn't. It helps.
Right. And depending on that patient's particular symptoms, may help more than the next patient, right? If that patient has a significant transverse deficiency, then the expansion is going to be more likely to be a more heavily weighted factor in improving their overall condition. If they don't have a transverse deficiency, probably not going to get the benefit. Same with the lymphoid tissue. If it's really obstructive, then removal is going to have a different impact than if it's not. There's an interesting article came out in September of 2025. We've all heard of the adenoid facies, and it's something, and I think all the medical and dental boards, it's part of it. And a lot of orthodontists actually question that that's even a thing, which is a whole separate discussion. But I would talk a lot about allergic rhinitis and the fact that it's estimated now that almost half of children suffer from allergic rhinitis. And of that, there are studies showing that upwards of 80% of those kids have some level of turbinate hypertrophy as a result. So great, go after the lymphoid tissue. If they can't breathe through their nose, as you said, it's a connected system. If the nose is obstructive from inflammation, it doesn't matter if they have negative lymphoid tissue in there. They could have a recess in that area. It doesn't matter because they're not going to get the air even to that point. So that calls in the multidisciplinary side, because now we've got to not only figure all this out, we've got to send this patient to maybe the allergist, or in an adult too. I saw it in adults who were having these issues, and to the allergist and the ENT and maybe the sleep physician. And at least in my world, these patients usually just came in because their kid or they had crooked teeth. And you're like,
you've chased it all the way, the why back to kind of why it's going on.
Yeah. And so that, I think, gets to be the challenge and why it's hard in the dental arena. And then, as we talked about, and I want to finish up here by hearing a little more in detail on the process you've developed with sleep, because I'm so fascinated by it. We then don't know what to do with that patient. And that's really scary, because we then send them to it. We take the leap and we feel like, as the orthodontist, we know we're not the physician. We know we can't diagnose obstructive sleep apnea. We know we need our medical colleagues on board. We send them to our medical colleague, and the medical colleague says nothing to see here. Or they go for a sleep test, a sleep study, have polysomnography done, and it comes back as nothing, right? Or mild, right? Or in a child, non-existing. I've told the story before on the show. I had a patient with one of the residents I was working with who was just turned 6, and all the classic signs of sleep disordered breathing. I knew it. My mom sent me a video of him, suffocating to breathe at night, everything. And we sent him to the ENT. We took a CBCT, had obstructive adenoids. Send him to the ENT. ENT sent him for a sleep study. Sleep study comes back as 0 for AHI, normal. So I started asking mom some more questions about it. And mom was super in tune to all of this. And it was, with being that I was teaching a resident, I had been talking to mom quite a bit about this whole field, because I was helping educate the resident as well. And mom brings a sleep study, and I look at it. I'm like, okay. And I said to mom, tell me a little bit more about the study. Knowing that first night effect from you and Jane and Shapiro in 2012, knowing that, I said, tell me about that. Did he just go for one night? Yes, of course, right, always. And I said, did you get a feel for how he slept? And she said, Dr. Luke, it's the weirdest thing, because they woke him up and stopped the test at 4:30 a.m. And I said, what? And I mean, anybody who knows anything about the sleep side, I'm certainly not telling you this, that, for kids especially, if they're going to have those episodes, they're going to typically have deep REM sleep later in the sleep cycles. Even if this little guy was going to have an episode of 10 or greater seconds or 2 successive breaths, which, as we all know, may have not had that anyway, even though he was severely suffering, it didn't pick it up. And mom said, the orthodontist said there's a problem here. And he said, what does the orthodontist know about sleep medicine?
It gets, I think that you're right. And that just, I've been told that as well by ENT. So my patients have been told, he's a telemedicine doctor. What does he know? I'm like, okay,
deep breath, literally.
Yeah, I mean, it's again, there are people that will act that way, and I think one of the things is, I think the parting shot I would have is, you don't have to work with them. We're there to help you. And so, what we want to do is make sure that there's access to care, there's access to professional care. And, the idea is that you have a partnership that works, and we're there to help, because I think we've heard the story so many times. Even we face it sometimes. And thankfully, we have our board certification, and we can kind of get them referred to somewhere else and say, if you don't understand our philosophy of how to help patients, we'll work with someone else. So the idea is to make sure that we are addressing this as best as we can, because again, patients are being unheard. They're being tossed aside, pushed aside, saying, this is, it doesn't matter, because at the end of the day, if a patient's struggling, if you haven't answered that question, then what could it be? Right. I know you're a surgeon, but at some point you have to kind of look and say, okay, yeah, a good surgeon. My dad-in-law is a great surgeon because he's part physician, part surgeon, the way he behaves. And, it comes back to, what else is going on? How can I help you? And I think, frequently that's why, I've been really relieved being able to work with our dental colleagues, because we can circumvent the system of them having to go back to their primary care doctor, which then is another stumbling block, because could your primary care doctor get a sleep study? Primary care doctor says, no, you don't need one. Or it's a negative test, or it's a mild test, or I'll send you to a sleep doctor, and that's going to take 3-6 months, and the patient falls off, the wagon. So, I think a lot of times, one of the things is we need access to care. We need patients who are able to meet people who actually want to serve their needs, want to help them out. And that's what we basically do. I mean, it's easy enough. You come to our website.
Yeah, if you could talk about that. And I'll put the links to the website and everything in the show. But if you could, just to close up, maybe just paint a little bit of a picture, both for a patient, because I do have a lot of patients that listen, as well as for, say, a dental provider. How would they utilize your services?
So, for a patient, it's as simple as it is for a referring practitioner. Okay. So for a patient, if they recognize issues, or they've not been heard, or they feel like they have a sleep issue and they just don't have access to care, you just come to our website, sleep.com, SL3Is and a P.com, pronounced sleep. It was the cheapest way to buy the word sleep at that point. So, you come to our website, there's a big book an appointment button. You click on that. It will get you to answer some basic questions. It put in your insurance information. If you choose cash pay, we have cash pay rates as well. You book your visit. We verify your benefits before it's booked. You can, we have availability within 2 or 3 days of you booking. Okay. So you don't have to wait long. We do have some Saturdays open as well, but it's the idea is you get seen, you verify through your insurance, you pay the same copay, it's on your card, the same copay amount, same specialist office visit. Nothing changes like what you normally do if you walk into a bricks and mortar type sleep practice. Once the visit is done, what we're doing during the visit is actually trying to document your symptoms, connect the dots with your health issues, trying to get a clinical gestalt on whether you have something here. If they need a sleep test, we order a sleep test. We do multiple nights of testing. We do 2, if not 3 nights of testing. Again, through the insurance, we, within a day or two of getting the order, the insurance doesn't require prior auth. The test is mailed out to the patient's home. Instructions included. There's an 800 number to call for technical issues. Once again, with testing, return the device, return label included. We will interpret the results and immediately get their patient scheduled for a return visit. This process, depending on some patients, we've done a 5-day turnaround for one patient. Wow. Actually, it was 4.5 days, where that's amazing. They came to see us on a Thursday, and on a Tuesday morning, he was already scheduled to see us back, because we shipped out the device on a Friday. He got it on a Saturday. He tested Sunday, Monday night. He shipped it back to us. Now, we don't. The kicker is we don't have to get the test kit to actually interpret the data. It's uploaded to the cloud, so I can already interpret the result, get them seen, and then during the follow-up visit, that's when we discuss treatment options, what your results were like, what it means, next steps with whichever therapy you choose. If it's negative, is it a real negative? Is it a false negative? And if it's a real negative, then what else do we need to do to kind of help you with your sleep? But many of them end up having sleep disordered breathing. We'll talk to them about treatment options. We'll prescribe the oral appliance if they offer an oral appliance. We will send them to the closest sleep-trained dentist to their homes. We have no financial relationship with the dentist. It's like if they come to us from a medical practice, we will look for the closest sleep-trained dentist. Frequently, they will be referred from a dental office that is involved in sleep dentistry. And, they have a great setup, a great screening process. We'll send them back. We always do the follow-up visit schedule, automatically scheduled at 4 months, to make sure that they have enough time to get the device, get it customized, get it adjusted so that, the snoring resolves or the sleep issues resolve. We see them back to make sure everything's on track. Because at that point, then we do the efficacy testing as per the guidelines, the AADSM guidelines, to make sure that we don't just trust the subjective improvements that we have, because so many patients have concurrent heart disease or heart disease risk. We don't want anything triggering their sympathetic drive if we can avoid it. So that's the patient journey with us. We end up seeing them long-term. So once they get on therapy, even on a CPAP device, we have sleep coaches assigned to them. It's our respiratory therapist that does a video call with them, show them how to use the device, how to wear the mask, how to keep things clean. And then they enroll them in our sleep coaching program for the first 90 days because it takes a freaking village. It's not just about shipping a CPAP and going Godspeed and good luck. The devices are great, but they need to be customized. They need to be adjusted for you. The mask needs to be changed. We need to hear patient feedback about what is going on with therapy. Why isn't it improving? And what we need to do to adjust the device. Because again, we shouldn't blame the patient. It's your fault. You're not complying.
Right.
We would love to be compliant. I want to put on the mask and just fall asleep. Great. If that's what happened to most patients, I wouldn't have a job.
Right.
But it's not easy. It requires us to actually listen, and going back to what I said, give a shit about actually solving the problems. Why are you still not able to use it? Let me help you solve the problem. Again, with cloud technology, we can change device settings easily from our side. All we have to do is with our sleep coaches and myself and all our practitioners, we kind of figure out what the symptoms are, issues are, and then we adjust the settings accordingly. And then we see them back long term. If they have that or they have restless legs, insomnia, we do CBTI, we manage that. We manage everything from nightmare disorders and so on. So any sleep issues, because we're managed by board certified sleep physicians. So that's the patient journey side of things. From the referring office, it's just as simple. There's a referrals tab on our website. It's on the top right corner. You click on that. You put in the provider information, the basic information they will need, the patient information. We have a Dropbox feature there where you can put in the patient's demographic information and so on. And then to ensure that they actually get to include their medication list, insurance card, whatever thing that they think is helpful for us. And the added option that we just created, which I'm kind of excited about, is that if you can actually book the appointment for the patient. How many times do you get to actually see your referring office's schedule?
Neat. So not often. That's great.
If you see Miss Smith and you're like, Miss Smith has got 3 kids and she's already struggling and so on, you can say, hey, Miss Smith. And all we have to do is this, all that referral, if you can provide us their medical help, their medical insurance information, that will allow you to take to the next page where you can actually book the appointment for them Thursday next week at 3 or Tuesday at 4 o'clock. You just ask them before they left your office, they already got a text message confirming the appointment for you. And then you have, we verify all the benefits beforehand. We send all referring offices a consolidated list of all their patients the past week. So for the past 90 days, every week we send them out a what we call a practice update, all your patients and where they are on the treatment journey with us. And every time they see us, they also get the clinical notes. For the dental offices, once we have the follow-up visit, within 24 hours, they get the prescription, the clinical notes, the test results, so they can move forward with the oral appliance to the next step, and then we'll see them back. The idea is to make it easy. I mean, it shouldn't be difficult. It shouldn't be tedious. We're easily contactable. We make mistakes as well. And I have dentists emailing and saying, hey, could you take a look at this patient again? I think you'll miss something. And great. We know we're not perfect, but we want to make sure that we're there and available and not kind of condescending in our attitude, because there's a lot of things that we just don't know yet. And we have to be open-minded to kind of feedback as well.
Age-wise, is it...
teenagers.
Okay.
Yeah. 13 and above.
13 and above. Okay.
All the way to adulthood. Yes.
Okay. Awesome. So great. I really appreciate you not only coming on the show, but what you're doing, the journey you're on. This is one of the most fun things about doing what I'm doing now in this capacity is getting to, if I hadn't been up there speaking in Atlanta and Andy had invited me and then I'm up there and then you're there, it just, how these things happen. And then
you would have been siloed. I would have been siloed still trying to figure out how to get in touch. We do work with our dental practices, but hearing you speak really just made me realize, thank God that people out there seeing this, what I'm seeing right now, and understanding that there's so much where the system is not supporting patients. And unfortunately, like we started talking about, a lot of practitioners kind of co-opt into how the system works and just kind of doing that 5-minute consultation and just missing that 800-pound gorilla in the room because you're just trying to be tunnel vision.
Yeah, well, it's so true. And I can't thank you enough. And I'm sure that there are going to be people reaching out to you, and I will continue to recommend your services in sleep. When we met the one time I hopped on with you, I saw the utility, the interface. It's so slick. It's so intuitive. It really is. I see, honestly, this being the way of the future for healthcare, especially once we get AI having more of a role. People are fed up with the traditional system and the sick care model that it is. And so I appreciate you being there to do this and to share it with everybody and taking the leap you took. And yeah, just really enjoyed having you on the show and getting to talk with you and getting to know you as well. It's been a lot of fun. So Dr. Avi Bhar.
No, likewise. Thank you. I think we all have to change. I think that otherwise patients are going to vote with their feet. That's why That's why they're going to social media. That's why they go to all these places, because they actually feel like someone's hearing them and trying to solve, even though it may not be all accurate. But that's kind of how we behave. If we don't find help in one place, we'll keep looking.
That's so true. No, I really couldn't agree with you more. So it's been an absolute pleasure. Dr. Avi Bhar, thank you so much for coming on the show and sharing with us.
Thank you. Good to be here.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.